prevention of gynecologic cancers, as well as that big topic of menopause. Many folks have been asking about menopause, early menopause, all the different side effects that come with early onset menopause. So they are here and are giving us a lot of time for Q&A as well. So will you please welcome Dr. Paul Lin and Dr. Jennifer Park.
Thank you very much for the introduction, and thank you for coming. What I was prepared for was to talk about menopausal issues, which I think is a big issue, but I know nothing about menopause, and that's why I brought it in. And I also am a gynecologic oncologist, and I also wanted to just give a brief review on prevention of the more common gynecologic cancers. So I have a slide set, but I wanted to see if you would like to just start off with a Q&A session first, maybe about menopausal issues before we go on and talk about gynecologic cancers. Would that be okay? Sure. This is Dr. Park. She's the expert.
So my name is Dr. Jennifer Park. I work here at Huntington Hospital. I'm a general gynecologist, but mostly what I do, I treat a lot of women in menopause. I do hormone replacement, but we also offer other non-hormonal. For those who cannot take hormones, there are some non-hormonal options for symptoms and treatment. So, do you guys have any specific questions to start with, or? Yes.
Being on an AI inhibitor, being older and mature. Any suggestions for sweating from the AI inhibitors?
There are, so that's
When
number
you've
one.
already been through menopause.
There are some newer medications that are available now for hot flashes, and the target of this new class of drugs, you may have heard of, you may have seen commercials on it, but it's called Veoza, and there's a couple more drugs that are coming out in this line of drug, and it is more targeted at the thermoregulators in the brain. It's not estrogen-like at all, but we definitely know with the loss of estrogen that our thermoregulation just goes haywire. So there's a whole new class of drugs that are designed to target that. Generally safe, and it probably would help with sweating as well. But
Yeah,
that's not estrogen-like. Yeah.
I just started it. I was wondering if you can explain with these new drugs that are not hormone functioning, what part of the brain they work on and how they signal.
Yeah, it's really more the thermoregulation, the thermoregulators in the brain. So with loss of estrogen, it just kind of goes haywire where we have these intermittent hot flashes and sweating. So it binds to those receptors that estrogen. It's not estrogen-like, but it helps with that regulation. I don't know how to explain it on a molecular level, but that's where the target is. There are some herbal supplements that do the same thing. So that's kind of the newer thing in terms of thermal regulation, and that's pretty much all we can kind of offer at this time. So,
could you tell what AI stands for?
Oh, it's an aromatase inhibitor.
Thank you.
Yes, so yes, it's a commonly used medication.
It blocks your estrogen.
Yeah.
It's a lovely thing.
Yeah.
I'm on that path, so that's what I thought.
Okay.
I didn't want to make an assumption.
Yes. Yeah. Oh, sure.
Realizing that this poll is a little bit obstructed. Also, quick reminder, can you please put your cell phones on silent or turn them off? Forgot to warn about that. Thank you so much.
Thank you.
Oh, yeah, sorry, I hope I answered it well enough. Yes.
Talk about AI. If you are on AI for 6 months, the side effect is so strong. What can you do?
Well, what side effects are you specifically? We always have to target the side effects kind of each one specifically.
It's a pain on the joint, muscle
Yeah.
pain, night sweat, headache, and cannot sleep at night. A lot of side effects. Your heart rate is high, heart rate, you have AFib, all kinds of side effects. So you off AI, what would be the outcome?
Oh, well, you mean going off of the aromatase inhibitor? I mean, that.
Go off of AI. Because I'm currently on natural. Is that natural? The first one, natural, right? Natural, yeah.
Yeah.
So the doctor recommended the other one, which is a hormone. is, there's three, right? You have letrozole, and there's something. But that particular one is hormone-based. Is there any difference between the two and the hormone-based AI?
Well, okay, so those, unfortunately, I'm not well versed in those, because that's mostly falls under breast like a breast, cancer doctor who does those. So I don't have those options for you if you can't be on, I don't know the difference between those. So that's unfortunately not my field. So I apologize, I can't guide you better. And same even, I don't know, Dr. Edge, can you answer that question? Because it mostly falls under breast oncology, and we're not breast oncologists.
It's a great question.
Yeah.
And, I defer these issues to the breast and oncologist.
Yeah.
May I ask who your doctor is?
My doctor is in Kaiser.
At Kaiser. Yeah.
It's not.
I do have certain patients who have breast cancers treated by their breast cancer medical oncologist. And sometimes they have to switch to a different aromatase inhibitor depending on their side effects, but it's not something that I'm very familiar with.
For you, ma'am, you're on AI too, right? What are you on?
I'm on letrozole,
Letrozole.
and I thought about doing what you've done, but to me, I'm not gonna swap out one side effect for a baby.
Do you
So I'm
have,
just sticking
the worst part is me is the night sweat that I don't sleep. And then it's a pain, I can hardly walk.
You need to talk to your oncologist.
I did, she called me off, she said maybe for a month or two, we'll see. But she recommended to get on the third one, which is hormone based. And I don't know, not hormone based, what's that?
Was it called tamoxifen? No.
Because I'm post menopause, so,
There's three of them.
yeah, three of them, the one, X something, yeah.
Exemestane?
Yeah, that's it, that's the word, yeah. But that one is, two of them, which you on one and I'm on the first one, MG, yeah, but the side effect is so severe. I couldn't believe it, yeah. One pill will cause you all kinds of problems, yeah. So I'm off for a month, the aches and pain kind of disappear, but I still have nice sweat and head. The side effect is still there, took a while, still there.
And like the doctor said, talk to your doctor.
She recommended me to talk, I did talk to my doctor, she was sweet, she said, come back in another month, she says it's a new one. But do you have any side effects on that?
Thank you.
Yes.
Could you speak to, like herbal supplements and how you can maybe supplement some like prescribed medications and like you're saying, like the night sweats or?
Yeah. So there are some herbal supplements available to help ease some of the menopausal syndrome. So there's a company, it's called Bonafide, and their website is hellobonafide.com. And they have a lot of non-hormonal nice options for menopause, which one of them is called Relazin, and it is again, it's made of a pollen extract. It's not estrogen-like. And it's meant to, again, target the thermoregulators in the brain. So it is helps with hot flashes. And all of these things, yeah, give a good 3 months for that. They also have a vaginal moisturizer called Reverie that helps. It's just an insert of hyaluronic acid. So that's a nice moisturizer, which I recommend for a lot of my patients who can't take any kind of estrogen to keep the vagina from getting dry. So that's another nice option. So that company, I think, puts in like a lot of nice herbal supplements.
So, okay, so I'm married, I'm sexually active, so that's good to know.
Yes.
But what about vaginal health as you go forward with that? Like, I mean, there's just so many things that could go wrong.
Absolutely. And there is a big push even with urologists about putting just the average menopausal women on a little bit of vaginal estrogen just to keep those tissues healthy and just to prevent UTIs and such. Vaginal estrogen we've always felt safer with than any other form of estrogen because it stays in the vagina and just works very locally. But again, I think for those that have breast cancer or have estrogen positive cancers, we still have to approach that with a lot of caution.
Yeah.
But that is one option. There's also an intravaginal DHEA. DHEA is a precursor to estrogen and testosterone, but there's some receptors there, but still considered a hormone. In a way, still considered a hormone. And then the latest we have is there are some just procedures you can have done in the vagina. So there's like a laser, vaginal laser. And then there's also, there's actually a newer treatment. Actually, I have this device in my office. It helps, it uses ultrasound and radio frequency to target the cells in the vagina to produce more hyaluronic acid naturally. So that is available. It's called the MPEM. I actually have a pamphlet in the back. It's just new technology. You can actually do that on any part of the body. So your face, you can stimulate, you just target the cells that stimulate collagen, elastin, and hyaluronic acid, and you can have more moisture anywhere. You know, so your face, yeah. So you can do it. You can do it anywhere. You can do it down there. So, yeah, I mean, there's ways to kind of fight aging, you know, without hormones.
But that's an in-office procedure.
It's an in-office procedure done by someone who knows what they're doing. So yes, but
Darn.
but that is yes, but that is available. So that actually is a nice option for those who cannot take hormones, who are number one to keep your bladder healthy, but it also makes, you know, sexual intercourse less painful, less dry. So it is a nice option. So I have it's called the MFEM, EMFEMM. I actually have a pamphlet in the back. It's called the MFEM. So there's this procedure here that's a nice option for patients. And again, you can do, yeah, you actually can do it on your, you can do it on your face to get more dryness. Because I think that's one of the biggest complaints I get in menopause is dryness. Yeah. So dryness everywhere, eyes, hair, skin, you have the joint pains, all of this. So dryness is an issue. We can only do so much, but we can, there's just other procedures we can have done. So that is a nice little option, especially in the vagina. Again, yeah, the other complaint I get a lot is hot flashes, of course, and you know, unfortunately, they have surveyed women in terms of hot flashes, and the average length is 7 years. So it's nothing that we can just sort of wait out sometimes. So the Relazin is a nice option, and then again, this newer class of drugs called Veoza. There's more of that kind coming out, and I think they'll continue and improve. And I think the safety will continue to improve. Right now with Veoza, their warning is that we just need to check your liver. You have to watch the liver. There was one case of some liver damage, but we just have to watch for that. But some patients have just really raved about it. They were, you know, it just really helped them sleep. You know, it improved their, you know, improving sleep improves quality of life already. So those medications are very promising, and they just came out. So we're lucky we're moving in that direction in terms of that. The other, I'd say probably the other big complaint I get in menopausal women is weight control, you know, and weight gain, and the best we can say, and then also the other big thing is really bone protection is the other big thing, you know, we need to do that. You know, we can't give you estrogen, we've got to get you know, we got to keep those bones strong. So, you know, really the two most important things, skeletal wise as we age, is to keep our bones strong and to build muscle. So I encourage all my patients to do some kind of weight-bearing exercise. You know, make sure you get enough calcium, at least 1,200 milligrams a day, and that's divided, not all at once, but that's like 3 servings of milk or dairy or some kind of yogurt, milk, you know, cheese, any of those things, 3 times a day. Vitamin D. At least it kind of in units. We get D from the sun, but we're all wearing sunscreen and we want to protect ourselves. So D is usually in a oral form of either 800 international units or 1,000 units a day. Usually comes with vitamin C. So vitamin D, I mean the calcium. So just make sure they're together. And then do weight-bearing exercise. And by weights we mean, you know, weights, add them more than your body weight. So really what popular I've seen is the weighted vest, which is nice. So if you're walking, add a little extra weight. Also they say jump, kind of doing some kind of jump training, even jump roping alone for 10 minutes can build bones. So you need impact on your bones to keep them strong. So exercises like Pilates, although I love it, it's not enough weight on you. I still highly recommend Pilates because it helps your core and your balance. So balance is really important as well because we don't want to fall on, you know, brittle bones. So keeping your balance, keeping your muscle and your core strong, as well as just making sure your bones just in general are strong, are very important. And then building muscle. and especially the big muscles. So again, Pilates I like a lot, but I think it works more on smaller muscles. Well, you need to get you need your legs strong. To be mobile as we age, we need muscle. You need to be able to lift from a chair and lift from the bathroom and lift out. So, building muscle. So I would, if you can do weights, grip strength too. Really, really important as we age to keep it strong. So even holding on to like a dumbbell, try to work your way up. Hold them for a minute. Start with 10 pounds, then go to 20 and then 30, and eventually, if you could do 75% of your own body weight and hold it for a minute, you're going to be able to open things, as you get older. So, and that keeps our weight. So muscles burn more calories. So the more muscle you have, the better your metabolism is. And that's how we control weight as we age, just build more muscle ultimately. We do also have to eat better, eat less carbs. There's something about menopause that we can't eat carbs anymore. Not to eliminate them, but make them as complex as you can. Avoid the simple sugars. Avoid, a lot of pasta, bread, all that things. Limit it. And then just eat more protein, because protein again builds muscle. So eat a lot of protein, less carbs, and that's kind of the main way and the best way we can kind of control our weight. Question? Yes.
Okay, so my loved one, who's a female, received a pancreatic cancer diagnosis. She's fighting it, but we got an email that said if you have any cosmetics that have hyaluronic acid in it, throw them away.
Really?
Because they said that pancreatic cancer cells in particular feed on hyaluronic acid, which I found to be really shocking.
Okay.
Have you heard that?
I haven't. I don't know. Have you heard that too? Yeah. I don't know. Is it supplements or just like?
Well, they were saying like if you have something where
they like a topical thing. Okay.
Plump your skin up, don't put it on because those I don't know if anyone in this room has been affected by pancreatic, but apparently
That's
pancreatic cells thrive on that. Now, I didn't know that we produced it ourselves.
We do make
but,
it ourselves, yeah.
I guess they just don't want you to add that to your system. So that might be something emerging, but I just wanted to ask.
Yeah. No, I don't know, but I know there, a lot of anything, like any cosmetic has a lot of chemicals in it. So it's, I wonder if it's just a link to that, or if it's, if really the true cause is like the parabens in it, or, some other kind of formulation that's in those moisturizers. So no, it's good.
Specifically said the hyaluronic, but I don't know.
I know, that's a good question.
It was, and I'm sorry, I don't know the source.
I know, it's okay, yes, I know, yeah, exactly.
Come to you, but I was shocked to receive that.
Yeah, no, not that I'm aware of for that, but again, I probably want to make sure within like a link or a correlation, and maybe really the true cause is something, some chemical that's in the way we produce those kind of cosmetics. So, yeah, good question. Yes.
What about the correlation between calcium supplement and the cardiovascular disease?
Yes, I know. So that's like, I have heard of it too. So I try to tell patients really, as best you can, try to naturally get your calcium from food sources if you can. So again, milk, dairy, almond milk, many other milk substitutes. If you can't take lactose, maybe try to get it through dietary sources. Better than actually a supplement, just in case. I don't know the correlation, but it's kind of better if we just get it from our food anyway, as best naturally. So,
I'm sorry, what was the question?
About calcium supplements and heart disease and if their correlation. And I did hear something about that. And again, I don't know how valid it is, but try to get it naturally if you can. Would be my suggestion, and that's what I generally tell my patients. Yeah.
So asking for a friend.
Yes.
Premenopausal women and temperature control is an external temperature control. Is there any solution to that where somebody goes outside and it's really hot? And then it kind of exacerbates and kind of spirals into migraines or what?
Yeah. Again, maybe those supplements get thermoregulation. There's receptors there, for hormones. In the thermoregulars in our brain. So yes, that's as we're going through the change, we're going to feel that.
So how do you stop it?
Well, it's maybe then the new class of drugs or the certain medications that target the thermoregulation. Really, so, I mean, if you can't take hormones can help too. But if you can't take hormones, then yes.
my question is to what level that I need to go see a, doctor for that?
Oh,
Like how much or
It's
like a,
yeah.
like a
Yeah.
temperature regulation or?
Yeah, well, it depends how bothersome, right? Because if it starts to, wake you up at night and you can't sleep and then you're have fatigue and, it interferes with your daily life, then yeah, you should come and see somebody.
And what kind of treatment would that be? Would that be just
So-
taking hormone?
Yeah, well, so for those who take hormones, sometimes it is a matter of giving hormone, or again, we could do one of the kind of alternatives. But typically, because it's from hormones kind of are sometimes the best solution for that. But it's again, for those that can't, then there's the whole new line of medications are coming out for that. There'll be more coming very soon to help with that. So
My question, because I see my endocrinologist regularly.
yeah.
And for some reason, she didn't want me to take a hormone. She just kind of like say, if you can, not need to take it, don't take it. So what is the rationale behind that?
Yeah, I mean, I don't, well, so if you can take them, I mean, I have a little bigger discussion than that, but there's risks and there's benefits. So this is a whole group of cancer survivors. So, it's, the risk is cancer. I mean, like it's small, but it's light, but it is there. But there's a lot of great benefit too. So again, a lot of it is quality of life issues here. So, if you're having hot flashes and you can't sleep and then, you feel fatigued all day and then that lowers your mood and your mental well-being, and then we've got an issue. We've got a bigger issue here than risk. Like I said, risk is like taking a chance here. Like you may not get it. You may, so we have to deal with something that you're going to deal with every day versus something you may get, you may not get. So it's one of those discussions that is just individualized and it's long. And so I think I think that every doctor should be willing to have that conversation more than just. I don't think that's good enough advice. I think you got to talk a little bit more.
So is the right consultation with the endocrinologist or with the gynecologist?
Well, okay, so gynecologists, and not all gynecologists I'll say, but it comes more from them. Endocrinologists, strangely, they deal mostly with the diabetes and they deal with thyroid and they deal with the other hormones in the body, but we kind of deal with the female hormones.
Okay.
So, and just to find somebody who knows, because a lot of us do babies and obstetrics, so somebody who just spends a little more time in that field.
Ignore the endo, got it.
Yeah. But just get another opinion. That's all I think. Yeah. Phytoestrogen. So those are estrogen-like. Yeah. So those are estrogen.
Okay.
There again, the thing is we don't know. So they haven't done studies on the phytoestrogen. So if you have a specific like estrogen-sensitive cancer, the phytoestrogens, again, we don't know. There hasn't been a head-to-head in terms of
So
safety.
you don't know soy milk, soy product is not good?
I don't
Or
mind.
estrogen?
I don't mind soy really, because I think we would have to get megadose it, to have it. Soy's a little estrogen-like, but if you're naturally just eating some in your diet, which is very common in the Canadian diet, that would be
Soy
fine.
milk, those kind of.
I've always been fine with those. I don't think there's a way the body can change it into estrogen, but it can alleviate some symptoms. It's fine. But again, we just don't have the data on it. If you have a specific estrogen, if you don't have an estrogen-sensitive cancer, then yes, by all means, it should be fine to take soy for phytoestrogen.
Sensitive cancer. Is
Yeah,
that okay?
again, if they're estrogen-like, so in a way they bind to they may bind to the estrogen receptor and trigger it in a way that we don't want it to. So I would sort of stay. I would
There's still lack of data,
I'm sorry.
still lack of data.
Yeah, lack of data.
Not
Yeah,
enough
because
data?
they just don't say herbal things that are just out there. They're not studied really. So you can buy them, but they don't have. Not like they don't have to go through the FDA approval as a drug. So you just gotta be cautious of what's there. I've seen estrogen over the counter. Like you can just, but I don't even know how that exists, but I've seen it. But so just be careful what you buy, kind of even over the counter. Like so, the better products are from Hello Bonafide because they're not estrogen-like at all.
No, I'm talking about the soy milk and tofu.
Oh, soy milk and tofu, I think are okay. Yeah, I don't think there's any way you can get that much.
Concentration is very small, right?
Yes, yeah, it's not that much to be harmful. I feel in any way. Yeah.
Hi, I'm your patient.
Yeah.
Anyway, could you just talk a little bit about the bioidentical hormones?
Yeah.
Because you know I take it.
Yeah. So by bioidentical hormones, we mean that those are hormones that come in the form that your ovaries make. So because what they actually used to give, the most commonly prescribed hormone replacement was Premarin. And Premarin is not, our bodies never made Premarin. So Premarin stands for pregnant mare's urine. So it came from a horse. It's very strong. It's very potent. We gave it in really low doses, but yes, it did take away your hot flash. So, but it's a strong estrogen. So the push now for when we give people hormones is to give it in the form that our bodies make. Human estrogen, essentially, is what we mean by bioidentical, and it's basically called estradiol. And that's how, if I were to give somebody hormones, that's the form I would want to give it to them in, is estradiol. We also prefer hormones not swallowed. And that's the other problem with Premarin, is that it was swallowed. So estrogen that you swallow goes to your liver. And we do see an increased risk of getting a blood clot when you swallow estrogen. It's a known risk for anyone on a birth control pill. But the same thing can apply, and they have studied pills versus estrogen patches, and there's less of a risk for getting strokes with the estrogen patch. So that's when someone, that's all I mean by bioidentical, is that it's estradiol. When you're getting estrogen, if you ever get estrogen, you want it in the form of estradiol, and not a Premarin or a conjugated equine estrogen. Those again are more synthetic forms, they're stronger. So we want to give your body something that it's used to seeing.
What about the vaginal cream?
The vaginal cream is estradiol. The vaginal cream is estradiol.
Does that have the same effect on the rest of the body?
It doesn't. So vaginal estrogen, again, just stays in the vagina. So it will only work locally. So that's a plus and minus, right? So if you have an estrogen stimulated cancer, of all the forms of estrogen, that would be the one that you can maybe use, because it would just stay in the vagina and not get into anywhere else. But it won't alleviate hot flashes, for example. So it won't give you any benefit. It won't give you any bone protection. It won't give you any of the other benefits that estrogen in another form would give you. So. Yes.
Is there a risk to not taking hormones if your symptoms are manageable? They don't bother you?
Yeah, right. There are some health benefits that estrogen can give you. Well, number one is the bone. You're right, the bone protection. But we can help our bones by taking calcium, vitamin D, and doing weight bearing exercise, as we just discussed. So that one is somewhat preventable, and also there are medications, right? Non-hormonal medications. Now you would see an endocrinologist for. So that was what you would want to see an endocrinologist for, is for the bone medications that prevent loss. So for bone, that is a health benefit that estrogen gives you that you can get in another way. A lot of studies are showing less heart disease in women who are on estrogen. But again, we can keep our heart healthy by doing good cardiovascular exercise, eating a good heart healthy diet. And then there are better tests for the heart that can look at heart disease nowadays, and then maybe a statin or something else we need. So that's the heart. Newer and what's coming out, and eventually will come out, is brain health and estrogen. So some studies have shown less Alzheimer's in patients that were on estrogen. So that is yet an upcoming, and I'm not sure how we can replace that if that is the cause, but they will come up with something if they're finding what the mechanism for that is. So that may be a benefit we may not be able to replace, but we can keep our minds healthy by practicing memory, doing memory games. I encourage my patients to do and practice memory, learning new skills as we age, learning a new language, reading, expanding our vocab. It's never too late to learn something. So if we keep using our minds, our memory will continue to be good. Brain fog is a big complaint I hear from a lot of people, and I think part of it, I'm guilty as charged, my phone. My phone, I don't know anybody's phone number anymore. I can't memorize anything. I just punch a little button, and even the text, punch in the code, and I don't even have to know what the code is for 2 seconds. And so if we don't practice our memory, we'll kind of lose it, right? So there's apps for games. And again, I think learning Duolingo, learn a new language, or I watch K-dramas, so listen to a new language and read subtitles and such. So we have to constantly work our minds to keep everything healthy and strong. So we work our minds, we work our bodies, and then keep our heart healthy. And this, yes, you can very safely do it without hormones. It helps with hormones, but you can do it safely without hormones as well. Yeah. Yeah.
What is the best hyaluronic cream? The hyaluronic acid cream for vaginal dryness?
For vaginal dryness, I like the one that's actually on that Hello Bonafide site. It's called Reverie.
How do you spell it?
Yeah, it's REV. REVAREE.
Referee?
Yes, Reverie.
That cream?
It's a little vaginal insert. Little insert. That's, yeah.
Prescription.
No, over the counter. Yeah, over the counter. And you put one little insert in every 3 to 4 days.
3 to 4 days.
Yeah,
Okay.
and yeah, as needed regularly for dryness. Oh, REVAREE. ARE. Yeah.
So I have, oh, go ahead, in the back.
Yeah. Yeah.
About what percentage, say, of the patients comes from already having, let's say, a breast cancer, and then take tamoxifen, generally prescribed for the perimenopausal crew.
Yes.
Now,
Yes.
and the AI is for womenopausal. So, yes, because I'm not a man, womenopausal. But it just never resonated. So I said, like, I'm wondering what percentage of people after being on that, because I know it's a small percentage risk with blood clots and uterine cancer.
Yeah.
After taking that, and then if you're in a situation like I am, which is a HER2 triple positive breast cancer, I'm being faced with the journey of, and I'm at that decision making point right now of the AIs, which I'm resistant to just because I'm not a tech person, and the fact that it sounds like artificial intelligence jumping in my body is even more disturbing to me. But I have to decide between these AIs, which are losing 25 to 30% of our bone density for at least on average 65 to 70% of women. That's daunting, and then I can't take collagen on top of that, and they want to shut down all my estrogen, and even my progesterone levels are challenged a bit. But that's a lot already, and then it's like weighing that between tamoxifen, which is the blood clots and uterine cancer risk. So I'm right now trying to decide between two major risks, and the right one. And I can do all of the others, the holistic things. I just came from yoga class. I'm trying to lift weights. I'm eat right. All of that, but I still am looking at the pressure that you get when you get the type of diagnosis I get. Of like, you have to do this. There's no other way, which I don't necessarily believe. But I'm trying to be open to allopathic and holistic as a balance and embracing them both. But I feel like that ugly little time ticker pressure, like something's forcing me to make a choice, and all the pressure is on me. No one else can make it.
I know.
And it's like, which path do I take? And are there only two? So, and I know everybody in this room, well, almost, has probably gone through that already. But I just finished my three months of chemo last month, and so I'm like, this is all new to me. So I come to all of the workshops to learn as much from other people. But I'm throwing this out there because all you can probably give me is data and statistics and like what things that pharmaceutical companies done tests on to give those results, right?
No, I know. So, unfortunately, that is what we're left with. But yes, still ultimately, it is a choice, and it is a balance between, once again, risk of recurrence, right? In your case, risk, versus that benefit, right? So we have to kind of decide what's better. Because the risk is, again, it's a risk. You may never get it. You may never get it back. We may have got it, and that's it, and you'll never ever get a recurrence. Versus what you have to live with day to day. So you got it. That's a hard decision, and it's something you have to talk individually with your doctor about making that decision. So the whole theory, toxin is really an estrogen blocker. So if you're still making estrogen, you got to block it really, and it's supposed to be as selective as we can to the breast. Well, an aromatase inhibitor, what these AIs, the aromatase inhibitor are, is it's an enzyme blocker, like it's an aromatase inhibitor. So the only estrogen we're making in menopause is this one called estrone. So there's actually different forms of estrogen that we make through our lives to make estradiol, so it comes from the ovary. So that's what I meant by the bioidentical estrogen 1 estradiol. That is what your body made, in most of its reproductive years is estradiol. It switches. When you check someone's hormones in menopause, estrone is the most predominant estrogen in menopause. We don't make a lot of it, but that's the only one. And the aromatase inhibitors prevent a conversion of the bodies to make more estrone. So that's it. So I don't know, for some patients on A's who have struggled, you can have your estrone level checked. Is it high? How high is it? Is it doing anything? Is it even doing anything? Is it worth all of those side effects that you're having from it? You could have an estrone level check, because that's what it's purposely trying to do, is lower estrone, because that's the only estrogen type you're making right now. You're not making estrogen anymore. Luckily in menopause, if you're in menopause, you'll be making estrogen. So we've got past that, at least natural production of it, but estrone's the only one left. And that's what the AI is. But if your levels are not high, maybe you can get away with not using it and also not having that risk. So it's
I
just,
need to see a hormone specialist.
well, in conjunction with your oncologist, right? You want to
Right.
make sure you're not doing any harm, but we're doing, the right thing. But again, we want to minimize risk but maximize just benefit, right? So everything we do is risk benefit in medicine. Yeah.
You do the test through what, blood?
You can do a blood test for estrone. I mean, that's the purpose of the inhibitor, is to, inhibit the production of estrone, really, is what an aromatase inhibitor does. So,
Do you know anything about, like, on the cutting edge in lieu of bisphosphonate? If that's how.
the bisphosphonates? Yeah.
Bisphosphonates, right?
Ooh, yeah, there are some newer injectable drugs, but that isn't, again, falls under endocrinologist more. Yeah, Avista is also a SERM. Avista is also a selective estrogen receptor modulator. So these are drugs that are designed to work like estrogen, but they're targeting only specific parts. So Avista is estrogen-like. So what the nice thing about estrogen in your bones is that estrogen stimulates the cells that break down bad bone, and it stimulates the cells that make good bone. So with estrogen, you get bone turnover. So that's what's nice about estrogen. And then you can, again, when you do that weight-bearing exercise, the jump exercises, and you're stimulating bone formation, it'll make healthy bone. While the bisphosphonates prevent bone loss, right? So they're preventing the bone that's supposed to be broken down from breaking down, which is not technically the healthiest bone. So your density will increase, but your bone health might not be better, right? So that's kind of the difference between a bisphosphonate versus something like estrogen. So Avista is estrogen-like, that's close to estrogen like, and can cause that cell turnover, which you want.
And that's a shot.
It's just it's like tamoxifen, so it's gonna have some high side effects. It's not a shot. There's new injectable ones that are also, I don't know the mechanism of those, but it's just a pill, and it's like tamoxifen though, so it may have hot flashes. It might have hot flashes and some other side effects, some vaginal dryness with Avista. So that's kind of the negative with Avista. So yeah.
Thank you.
Yeah.
When you reach 65, let's stop the pap smear.
Oh,
Is
yeah.
that okay?
I don't. I mean, I don't. I do. I still do pap smears on. I mean, it's cancer screening, right? So I mean, I always feel like the logic behind stopping, and Darlene can go in more to the cancer screening there, but I just think when
You still have to do it, right?
I do it. It depends on the person. So again, HPV. Yeah.
It's a good question.
Yeah.
It's a very common
Yeah.
question that I get. So it's a public health issue, where the women past 65 still get cervical cancers, and we do pap smears to prevent cervical cancers. But the thought is that it's very uncommon for women who have had regular pap smears, and if they're normal before 65, to get cervical cancer. So it's an issue of getting the biggest bang for the buck. It's been felt not to be cost effective to generally screen women over the age of 65 to 74, depending on which guidelines you read, because the likelihood of it being cost effective to prevent cervical cancer
So it is
just
only,
not there.
only cost effectiveness? So meaning, if you are okay from 60 to 64, your pap smear is normal.
Yeah.
Then 65, they stop
Then the
it.
likelihood of getting cervical cancer is very,
Very
very
minimal.
low.
Okay.
So the biggest issue is that, biggest caveat is that you have to have had regular pap smears during your adult life. And if they are normal, it's very unlikely to get cervical cancer.
What if the result something like hyperplasia? It's not cancer yet, but it's hyperplasia.
Dysplasia, yeah, so dysplasia is the medical term for pre-cancer of the cervix.
So-
And that's the principle of pap smears, that we can identify women who have pre-cancer so we can treat it before it ever progresses into cancer. So dysplasia is seen, but in general, even women who get dysplasia, we don't treat these patients. The natural history of most women with dysplasia or pre-cancer is that it never progresses into cancer. And even for those who pre-cancer does progress into cancer, it probably takes around 15 years for pre-cancer to progress into a cancer. So if you look at the life expectancy of a woman, it's you're preventing very few cervical cancers by treating women over the age of 65.
So it is justified not to do a pap smear after you reach 65. It is justified not to do pap smear
Yeah.
anymore.
You know, I'm like Dr. Park. I still do pap smears on patients. So, because I'm a cancer physician, I want to prevent cancers. But if you look at the national public health guidelines, when they balance everything between the benefit and risk and the costs of doing these screening evaluations, there's an argument for stopping so we can use the money to do something else.
So it's only cost effective. That's the main reason.
It's a public health decision.
Thank you.
What are the preventive measures we could use as women to prevent gynecological cancers?
It's funny you asked that. So, I don't know if you guys want to go through a PowerPoint presentation, or I can just talk off the cuff. Do you have any preference?
Let's see the slides.
Okay. So,
There you go.
thank you, Dr. I'm sorry, I was hoping to be able to use that clicker. I'm gonna just stand behind here. Okay, so what I'm going to just talk about is, and thank you for bringing up this question.
You're welcome.
So the three most common gynecologic cancers are cancers of the cervix, cancers of the uterus, and cancer of the ovary. So if you can see this diagram right here, the cervix is actually part of the uterus, but from a cancer standpoint, we separate cancers of the bottom part of the uterus, the cervix, from the corpus or the main body of the uterus, mainly because there's different causes and different treatment options. What I'd like to focus on is just prevention and early recognition. So hopefully we can either prevent the cancers or identify it early enough before it becomes life-threatening. Oh, sorry.
There it is.
Okay. So what is the magnitude of the problem? Around the world, over 500,000 women are diagnosed with cervical cancers. And 400,000 women have uterine cancers, and 300,000 women have ovarian cancers. I'm sorry, the other part of the slide didn't show up, but if you look at a list of most common cancers in women in the United States. Cervical cancer is way down on the bottom at number 11 and not number 4 around the world. And the reason why we have this discrepancy between the incidence around the world and here in the US is because we have very good prevention methods for cervical cancer. In the US, uterine cancer is actually the most common cancer, followed by ovarian cancer. Sorry, I'm new to this clicker. Oh, okay, so that's what I want to show. If you look at it down here, cervical cancer is way down here in the bottom. And the reason for this difference is, of course, prevention. We have very good preventative methods here in the United States. So what I would like to talk about is the 2 prevention strategies for cervical cancer: HPV vaccination and screening with Pap smears. So what are the risk factors for cervical cancer, first of all? Well, women who have multiple partners or women who have partners who have had multiple partners are at greater risk for cervical cancer. Cigarette smoking and use of birth control pills also are considered a risk, but the risk is not very high with OCP use. So these risk factors suggest that there is a sexually transmitted agent that may predispose one to getting cervical cancer. We now know that in the mid-1970s, HPV, which stands for human papillomavirus, has been identified as that sexually transmitted agent that leads to cervical cancer. So we've used that information to be able to prevent cervical cancer. So virtually all cervical cancers, almost 100%, are associated with HPV. There are 200 types of HPV. Each type infects only part of the body. For example, HPV 1 and 2 cause warts of the hands and feet. There are 40 types that infect the genital tract. And amongst these 40 types, there are what's called the low-risk types and the high-risk types. The low-risk types are not associated with cervical cancer, but they are associated with cervical warts, genital warts, as well as low-grade precancer. The high-risk types are the ones that we are more concerned about because these are the types that can lead to cervical cancers. And the more common ones are HPV type 16 and 18. So most Americans, actually, sometime during our lifetime, most of us will have been exposed to the HPV virus. Most of us will have been infected. 80% of Americans are infected with the HPV virus during our lifetime. But most of our immune systems will eventually clear the virus. It's only those patients who have a persistent HPV infection. An infection lasts longer than 2 years. Those are the patients who can be at increased risk for cervical disease. And the cervical disease that we're talking about are the precancers and the cancers. So we now know that HPV infection is a prerequisite for developing cervical cancer. And using that information, we developed the HPV vaccine. And the whole goal of the HPV vaccine is to prevent an HPV infection. So it's more effective when it's given before one has ever been exposed to HPV. Because once you've been exposed to the HPV virus, the vaccine is no longer effective in preventing future infections. So because of this, I'm gonna skip a little bit. Because of this, when we give the HPV vaccination, it's usually in young boys and girls before they've ever been exposed sexually to the HPV virus. So the general guidelines are to receive HPV vaccine up to the age of 26. Even though the FDA approves the vaccine for women up to the age of 45, most insurance companies won't pay for it because they'll feel it's not that effective. So the other strategy that we have in preventing pap smears is preventing cervical cancer is pap smears. So pap smears was developed by a Greek physician in the 1920s, and since the 1950s, it has become universal here in the United States to offer screening with pap smears. And as a consequence of this, our rate of cervical cancer has decreased dramatically. Back in the 1950s, cervical cancer was the #2 cancer in women behind breast cancer. Now, if you remember from the previous slide, it's number 11 or number 12. And I think most of the women in this room will know what a pap smear is. It's essentially a scraping of the cells from the surface of the cervix, and those cells will be examined under the microscope. And the goal of these pap smears is to identify women who have cervical precancer. So we can either monitor it or treat it before it ever has a chance to progress into cancer. So I'm going to move on. The second cancer I'm going to focus on is uterine cancer. Uterine cancer is really the most common cancer in women in the United States. I'm not going to spend too much talking about uterine cancers because it tends to be a cancer that, even though it's the most common, over 60,000 women in the U.S. get uterine cancers. It's usually a very treatable cancer. Most women with uterine cancers are diagnosed with cancer at a very early stage, at a highly treatable stage. When we're talking about uterine cancers, there's actually two major types. There's endometrial cancer and there is the uterine sarcoma. So if you look at the picture of the uterus, we have the lining of the uterine cavity here. That's the endometrium. And that's the area where most cancers of the uterus arise from, endometrial cancer. Over 96% of all women who have uterine cancers have endometrial cancers. The other part of the uterus, the wall of the uterus, or the myometrium, is the other source of cancers, and they result in uterine sarcomas. But because most women with uterine cancers have endometrial cancers, for the most part, when we're talking about uterine cancers, we're talking about endometrial cancers. Sorry.
Dr. Lin, may I ask a question?
Yeah. Sure.
Forget it. Thank you. With the uterine cancer, what, again, I had asked earlier about tamoxifen, and there's that percentage. I hear anywhere between 0.35 and 2.5% of women who take it can get the uterine version. Which one of those two?
Oh, it's an endometrial cancer.
It would be to that one.
Yeah.
And the other part of that question is, what percentage of women who get that 90% type of cancer, the endometrial, also had endometriosis earlier in their life?
Yeah. I don't know the answer to that, but in general, we don't consider endometriosis and endometrial cancer that closely associated.
Okay.
Endometriosis is a very common condition, and we don't usually associate endometriosis with cancers. However, there is a rare subset of patients with ovarian cancers that arise not from the ovaries, but from endometriosis.
Okay, thank you.
Doctor, how do you screen for uterine cancer?
Yeah, so there is no screening for uterine cancer in general. And the reason for that is because uterine cancers, fortunately, is one of those cancers that's very easy to identify at an early stage. And it's abnormal vaginal bleeding. That's a symptom that we look for. In fact, we're talking medical school or during residency. Any woman who has any bleeding in their menopausal life should be ruled out for a uterine cancer. So as a consequence, because it tends to cause abnormal bleeding early on, it leads to a very early diagnosis for most women, and so it's highly treatable. So there's no screening modality in general for patients with uterine cancers. There are a subset of patients who are genetically predisposed to getting endometrial cancers. In those patients, we do screening with every 6 to 12 month biopsies of the uterus. But in general, we don't have routine screening for uterine cancers. So speaking of estrogen, so the biggest risk factor for most women with endometrial cancers is increased estrogen exposure. Back in the 1970s, when estrogen replacement therapy was very common and was given on its own without any other hormones, the incidence of uterine cancers were identified to be very high. It was due to unopposed estrogen. So we now know that for women who still have a uterus in, if they need to take estrogen replacement therapy, we also give them a second hormone, progestin, to counteract the effects of the estrogen on the endometrial line, so they are not at increased risk for getting uterine cancer. Obesity is also a risk factor for getting uterine cancer. And that's one of the reasons why it tends to be more common here in the United States than other parts of the world. It's not that the fat cells in our body actually convert one of the male hormones, androstenedione, to female hormones, estrogen, what Dr. Park had mentioned. And so in women who are obese, it's almost as if they're taking extra estrogen, and that can lead to increased risk for endometrial cancer. So as you were asking, the most common symptom of uterine cancer is abnormal bleeding. So any woman who is postmenopausal, who has vaginal bleeding, needs to be ruled out for endometrial cancer. And premenopausal women, if they have irregular periods, if other reasons have been ruled out, then an endometrial cancer should also be considered as a part of the differential. So that's all I'm going to, yes.
Sorry, 2 questions on that. If someone has endometrial fibroids in their uterus,
Yes.
Does that put them at greater risk for uterine cancer?
In general, not. So uterine fibroids are benign, smooth muscle tumors of the uterus. Back when I was a medical student, we used to think probably 50% of all women had uterine fibroids. But this was back in the 1990s. Now I think if we were to do an ultrasound on every woman in the world, we'll see that over 80% of all of us, of all of the women, have uterine fibroids. They're benign tumors of the uterus. And we sometimes will follow them, not because we're concerned that the fibroids will develop into uterine cancer, but we follow them because sometimes what we think are fibroids may not be due to fibroids and could be a uterine sarcoma. So the thought is we follow them just to make sure there isn't any rapidly growing tumor that was presumed to be a fibroid, which may be a sarcoma.
Okay, thank you. And then also, if you do diagnose it, if someone has that bleeding, how do you actually determine that it is cancer?
Oh, yeah, so it requires biopsy. These biopsies can be done either in the office, a uterine biopsy, or it can be done in the operating room with scraping of the uterine cavity, procedure called DNC. So the last cancer I'm going to talk about is cancer of the ovary. It's the second most common gynecologic cancer in women in the United States, but it's the most common cause of death from a gynecologic cancer. There's around almost 20,000 women who get ovarian cancers every year. And unfortunately, the majority of women who get ovarian cancers will eventually succumb from their ovarian cancers. And the reason for that is simply we don't have any good preventative approach or good screening approach to diagnose a woman with early stage ovarian cancer at a stage when it's more easily treatable and curable. The symptoms that are due to that may lead to a diagnosis of ovarian cancer, abdominal bloating, distension, early satiety. These are very non-specific symptoms. It's not like abnormal vaginal bleeding with uterine cancer. So that's the biggest problem that we have with ovarian cancer. We're not able to identify it early on when it's usually treatable or curable, I should say. There have been tests that have been used in hopes of screening and identifying women with early stage ovarian cancer, CA125 level, which is a blood test, and pelvic ultrasounds to look at the ovaries, but they're not very effective. And the reason why they're not very effective is because ovarian cancer in general isn't that common. And these evaluations quite often will identify patients who have false positive tests, false positive elevations in CA125 levels that will lead to unnecessary surgery. So the CA125 level was a test that was developed back in the 1980s. And in the early 1990s, there was actually a large study that tried to determine if CA125 blood test was an effective test in identifying women with ovarian cancers. And what the study showed was that for every 65 women who had an elevated CA125 level, who underwent surgery to try to prevent the abnormality, only one patient had an ovarian cancer. So if you look at it the other way, 64 women had unnecessary surgery. So because of that, we don't use it as routine screening.
I have a question.
Yes.
I called my interest of my yearly exam, and there's that. Well, now we're also offering she can test for the tracer for ovarian cancer, but Medicare does not pay for that. And I don't know, I can't remember what she called it for CA125. Is there another blood test that they're offering now, doctors?
There are other tests that are available, but to my knowledge, and these include tests like HE4 and other tests, but they're similar to the CA125 level. There just haven't been accurate enough.
Yeah, I didn't agree to it. I said, let me think about this. I was going to ask you after your lecture, what about it?
I'm curious as to what she is. A lot of primary care physicians will offer these tests in hopes of just identifying women with an early stage ovarian cancers. But in general, I don't really strongly recommend for the general patient population.
Thank you.
You're welcome. So there's no good easy prevention for ovarian cancers in the general population. However, there is a subset of women who may benefit from screening, and those are women who are at greater risk for getting ovarian cancers. These are patients who have a genetic predisposition, having something called a BRCA mutation. There are two BRCA mutations, BRCA1 and 2. These are mutations that are inherited from parent to child, from family member to family member, that greatly increases the risk for getting ovarian cancer. It also increases the risk for other cancers, including breast cancer, pancreatic cancer, and prostate cancer. In general, a woman's risk for getting ovarian cancer is around 1 in 70 or 1.4%. However, if one had a BRCA mutation, their risk for getting ovarian cancer with a BRCA1 mutation is around 45%. And with a BRCA2 mutation, it's 16%. So in these patients, yes, in these patients, we do offer screening. So in general, there's a 1 in 400 risk of having this mutation in the general population, but there are certain groups of women, the Ashkenazi Jewish women, their incidence of having a BRCA mutation is 1 in 40. It's quite high. So in these patients who have an increased risk for developing ovarian cancers, we do offer screening, mainly because the risk for getting ovarian cancer is so high, the false positive rate is much lower. So in these patients, we can screen with CA125 levels of pelvic ultrasound. And the idea behind the screening is not to prevent ovarian cancer like patients with cervical cancer, but in hopes of identifying women who have an early stage ovarian cancer that can be treated and curable. We also consider preventative surgery for women who have a BRCA mutations. And in these patients, we sometimes will offer preventative removal of the ovaries and fallopian tubes. That's all I wanted to cover. Thank you for your question. Any questions? I'm sorry?
What is the treatment for ovarian cancer?
It's a combination.
It's treatable.
Yeah, it's a combination of mostly surgery to remove it, especially for early stage, as well as chemotherapy to either prevent the cancer from coming back or to treat any active disease.
Why does tamoxifen increase your risk of endometrial cancer? And in your opinion, it's really hard for me to, like, when I'm judging these things, to take in the statistics to make a decision. In your experience, I mean, how great a risk is it? I'm trying to prevent a recurrence of one, but I don't want to get another one.
Yeah, no, so tamoxifen is a serum. It has anti-estrogenic effects on certain parts of the body, but at the same time, estrogen effects on other parts of the body. For example, it's given for breast cancer because it has an anti-estrogenic effect on breast tissue, but it has an estrogenic effect on bone, so it actually prevents osteoporosis and has an estrogenic effect on the uterus. So it's like taking unopposed estrogen. In general, I think, so in the past, tamoxifen was routinely given to prevent women from having a recurrence of breast cancer.
Right.
But nowadays, in menopausal women, tamoxifen is used less and less often because of the increased risk for getting uterine cancer. So aromatase inhibitor, which do not increase the risk of getting uterine cancer. So,
I mean, my oncologist recommended tamoxifen for me, even though I'm menopausal, because of the joint pain issues of the other. So that's why it just makes me uneasy. All of it makes me uneasy.
It is. However, we used to see women who get uterine cancer on tamoxifen more often than now in the past. And in general, it sounds bad, but it's a highly treatable condition.
Why is there a connection between the breast cancer and the ovarian cancer?
Yeah.
Usually, one lead to the other.
I think it has to do with there is an association. A lot of it comes because patients who have genetic predisposition to getting the ovarian cancers and breast cancer, someone with a BRCA1 or BRCA2 mutations, they're at increased risk of getting ovarian cancers and breast cancers. And the BRCA mutations are considered the kind of the major genes that are associated with breast and ovarian cancers. But there are also minor genes that can also increase the risk for breast cancer and ovarian cancer, but not to that same degree. So I think a lot of the association is because of genetic predisposition.
So for the screening for the BRCA 1 and 2, we only have to do once, right? Or do we have to continue? Because
meaning if you've done BRCA testing once, is that enough?
Yeah.
Yes and no. nowadays we have what's called multi-gene panel testing. In the past, when the BRCA genes were first identified in the early 1990s, 1989, 1990s, the testing for BRCA mutations was very basic. These genes are huge genes, and the testing tested mostly for what's called the coding areas of the gene, the exons. And whereas more sophisticated testing evolved in testing not only the exons, but the introns, which are also parts of the genes that may be important in resulting in a non-functioning BRCA gene. So it depends on the testing, when it was done. And nowadays, in the last 5 or 6 years or so, we've gone from just single gene testing, looking for a BRCA 1 or 2 mutation, to what's called multi-gene panel testing. So if one had just BRCA testing 10 years ago, and one was told it was negative, that may not be as reliable as what we have now.
Better just do it again.
Thank you. I think we have time for one more question.
I just have a question for you. Doing those tests, just as a consumer, how is that going to affect, as you as a physician, are you worried about your patients getting those types of tests for insurance purposes?
With Obamacare, that's the one should not be discriminated genetically, right? But yeah, I think it's still an issue, especially for patients who have to go out and sometimes buy their own insurance. Unless you're buying Obamacare-based insurance, I think it does matter because you're asked to fill in, do you have any pre-existing conditions?
Thank you.
Drs. Lynn and Park, thank you so much for please take the time to fill out the educational workshop evaluation in front of you. You can leave it on the table. Anyone who's the first time here would like to take the floor, please stick around and I will show you.
Like the alphabet. On the one hand, am I on it? Yes. I didn't realize that I was on that phone. No, I'm sure it is, because we did do an interview. Because they did interview me here. Oh my gosh, I never thought of that. Well, good for you. Oh my God, thank you. Yeah. I get it. Yes. Well, I'll tell you what, mine is my is in Beverly Hills. He's a better my children, and I've been with him 35 years. Anyway, I've established a relationship with her. He's sitting on this part of town. And so I go to her, have blood tests done every 6 months to make sure that I'm in balance, because I do take a blood replacement. So I have estrogen testosterone and testosterone use. And then has her measure my levels.
Yeah, no, I'm just
And
asking.
she also does the same bioidentical. So she's a specialized doctor, so she was, I just asked her information, so I said, you know, I had breast cancer, and so that kind of one of that very rare.
Sorry. That's okay.
I'm just one of those very rare.
So you can like send me a note saying take it and like send it to me.
Right, you know, very much.
No, not
I've been tracking
That's why I'm asking. So what's she doing now?
Things have been suspicious. Then I went in 6 months ago, again, started the whole thing again. This time they did another but I never had a program they're tracking. So every 6 months I go in for mammogram, ultrasound, MRI. Wonderful. There's other AI, there's they're kind of
Yeah. Well, you heard about he said about the loss of
and I've heard both sides, because my doctor is in Europe, and the vaccine is not so I'm still, which I know, I expect that to happen.
Right.
But my doctor, the one that knows, actually is, so I'm hearing two sides of the story. Anyway, I'll walk on that. I'm someone else that I start to talk, because I've heard that I was a candidate for going to, like what you're saying, you finished.
I never took it. I never did. I did not. And that was, I had my surgery at UCLA. The doctor who had the breast cancer surgery center told me, because I did a mastectomy, I have a margins were severe. She said, I would not advise you to take it. I don't think I would. So she said, that's kind of up to you. So I never did. I never took it. And, but I did go off like, yes, for 6 weeks. And so important, but fertility white is so important. Because they will tell you, she will tell you depends on your quality of life. Do I take the risk or not? My surgery was a few years ago, and I haven't had any issues since then. So I went off the hormones, and I was so